Hi, I'm here today at our annual Heart Rhythm Society meetings in New Orleans, and I have the pleasure of interviewing Dr. Romero, who is now a fellow at the Brigham, about this really unique study that was truly multinational and was done in a number of different countries. And I'm going to ask him to share with our readers. This is online in JACC, so they can go over the study in detail, but I'm going to ask you to tell us a little bit about the study, an overview of the study, patients enrolled, and the results.
Thank you, Ken, and thank you for the beautiful editorial that you wrote for the paper. Just briefly, this is a multi-center registry that evaluated or compared left bundle area pacing versus biventricular pacing in patients needing cardiac resynchronization therapy as a first-line therapy, okay? So we enrolled a total of 371 patients. Only 120 patients were allocated in the left bundle branch area pacing. The primary efficacy composite outcome was heart failure hospitalization and all-cause mortality, just to do a copycat of the MARIT CRT. And the primary safety outcome was a composite of acute and long-term procedure-related complications. Also, we evaluated procedural time, fluoroscopy time, improvement in left ventricular ejection fraction, and New York Heart Association functional class. The results of the study were very interesting because even though with a small sample size, we were able to demonstrate that we meet the primary outcome. The left bundle area pacing group had a significantly better response to in terms of heart failure hospitalization and all-cause mortality, mostly driven the superiority by heart failure hospitalization because there was no significant difference in all-cause mortality because the study is underpowered, and to prove all-cause mortality, the MARIT 7-year follow-up you need to follow the patients for years, and we only followed the patients for a median of 340 days. So we concluded that if left bundle area pacing might be an alternative to biventricular pacing using a CS lead, and it might be actually better if you try that technique first and not as a bailout from biventricular pacing.
This is great data. Thank you for sharing it with us. By the way, do you have any plans to follow these patients more long-term?
Yeah, we're trying to keep follow-up, but in Colombia and Argentina, it's very difficult to follow the patients for more than 2 years because of the healthcare system. It's very limited resources.
Well, I want to congratulate you on a really important study. JACC readers should go online, pick up the journal, and study this trial because it's the beginning of more data that suggests conduction system pacing may be superior to CRT. Thank you, Dr. Romero.
Thank you, Ken, for the kind invitation.